Now, ischemic maculopathy, it occurs due to microvascular blockage and it has worse prognosis as compared to other focal and diffuse maculopathy of diabetic retinopathy. Clinically, it is characterized by a marked visual loss with macular aneurysm, hemorrhages, mild or no macular edema, and few heart exudates. Fluorescent angiography shows areas of non-perfusion, which is in early cases are in form of enlargement of foveal avascular zone. Later on, areas of capillary dropouts are seen, and in advanced cases, pre-capillary arterioles are blocked. Now, cystoid macular edema results from the accumulation of fluid in the outer plexiform and inner nuclear layers of retina with the formation of cyst-like changes. Fluid may initially accumulate intracellularly in macular cell with subsequent rupture. In long-standing cases, smaller microcystic spaces coalesce into larger cavities and may progress into lamellar hole formation at the fovea with irreversible impairment of central vision. Cystoid macular edema is a non-specific manifestation of any type of macular edema. It is different from clinically significant macular edema, that is CSME. Presentation is with blurring and distortion of the vision. There is typically pre-existing diseases such as diabetes indicating their cause, although cystoid macular edema may be the presenting feature of causative or conditions such as branch retinal vein occlusion. The signs of which is loss of foveal depression, thickening of the retina, multiple cystoid areas in the sensory retina, best seen with red-free light using fundus contact lens. Optic disc swelling is sometimes present and a lamellar hole may be visible. Antler chart testing demonstrates central blurring and distortion and macular edema, CMO. Fluorescent angiography, which is characteristic feature of cystoid macular edema, early hyperfluorescent spots due to leakage that progress to a characteristic petalloid pattern of dye accumulation within the microcystic spaces in the outer plexiform layer. This is characteristic feature of cystoid macular edema in FFA. In OCT, cystoid macular edema shows cyst-like hyperreflective spaces within the retina with retinal thickening and loss of foveal depression. It is effective in demonstrating vitreoretinal traction and the presence of lamellar hole. Serial examination is commonly used to assess the response of the treatment. Other causes of cystoid macular edema can be ocular surgery and laser. Clinically significant cystoid macular edema occurs in probably 1 to 2% of eyes following phacoemulsification, but it is higher following extracapsular extraction, particularly if associated with complication. NDR laser capsulotomy may cause cystoid macular edema, but the risk may be reduced if capsulotomy is delayed for 6 months and more after cataract surgery. Pan-retinal photocoagulation, if aggressive, may occasionally cause CMO. Other procedures which can cause it, such as retinal detachment surgery, glaucoma filtration surgery, and corneal transplantation surgery, are sometimes followed by the development of cystoid macular edema. Retinal vasculature disease such as diabetic retinopathy, retinal vein occlusion, hypertensive retinopathy, idiopathic retinal telangiectasias, retinal artery microaneurysm, and radiation retinopathy can also lead to it. Inflammation such as intermediate uveitis, sarcoidosis, scleritis, birdshot retinochoroidopathy, multifocal choroiditis with panuveitis, toxoplasmosis, cytomegalovirus retinitis, and Behçet syndrome is also known to be associated with cystoid macular edema. Drug-induced can be due to topical prostaglandin derivatives and topical adrenaline derivatives in FAK high. Retinal dystrophies, which including CMO, can be include retinitis pigmentosa, Garrett atrophy, and dominant cystoid macular edema, condition involving vitreomacular traction such as epimacular membrane and vitreomacular traction syndrome. CNVM, that is choroidal neovascular membrane, fundus tumors such as retinal capillary hemangioma and choroidal hemangioma, even when located well away from the macula. Therefore, immediate preoperative and postoperative use of anti-prostaglandin, indomethacin, or florbuprofen or ketorolac iodine is recommended as prophylaxis for cystoid macular edema. In cases of cystoid macular edema with vitreous incarceration, anterior vitrectomy along with steroid and antiprostaglandin may improve visual acuity and decrease the amount of discomfort. Now, in this way, we come to the end of all the vascular disorders, including diabetic retinopathy, hypertensive retinopathy, all vasculitis, and all artery occlusions and vein occlusions. Now we will start with retinal detachment. Retinal detachment is a very important topic both theoretically and practically. But to start with definition of retinal detachment, it is basically it is separation of neurosensory retina, which I have told you 9 layers. That's why I told you in my earlier slides what is neurosensory retina. It is a 9 layers excluding RP. So 9 layers neurosensory retina proper from the, it is separation of neurosensory retina proper from the underlying retinal pigment epithelium. Normally these 2 layers are loosely attached to each other with aquaretinal space in between. Hence, actually speaking, the term retinal detachment is a misnomer and it should be retinal separation, not detachment, but we still say it detachment, not separation. Hence, it is a misnomer. Now, the classification of retinal detachment. Clinically, etiopathologically, retinal detachment can be classified into 3 types: pigmentogenous or primary retinal detachment, and fractional retinal detachment, or secondary retinal detachment, and exudative retinal detachment. Pigmentogenous RD affects about 1 in 10,000 of the population each year, and both eyes may eventually be involved in about 10% of patients. It is characterized by the presence of retinal break held open by the vitreoretinal traction that allows accumulation of liquefied vitreous under the neurosensory retina, separating it from RPE. The retinal breaks, which are responsible for pigmentogenous RD, are caused by interplay between dynamic vitreoretinal traction and an underlying weakness in the peripheral retina, referred to as predisposing degeneration. Even though a retinal break is present, a retinal detachment will not occur if vitreous is not at least partially liquefied and if necessary traction is not present. Hence, for pigmentogenous RD, both things are important: peripheral retinal break and PPVD, that is and liquefaction of vitreous. If any one thing is not there, pigmentogenous RD will not occur. So, what is the pathogenesis of pigmentogenous RD? First, dynamic vitreoretinal traction. Now, pathogenesis of is syneresis, that is liquefaction of vitreous there. Some eyes with syneresis develop a hole in the posterior hyaloid membrane, and fluid from within the center of the vitreous cavity passes through this defect into the newly formed retrohyaloid space. This process forcibly detaches the posterior vitreous and posterior hyaloid membrane from internal emitting membrane of sensory retina as far as the posterior border of the vitreous base. The remaining solid vitreous gel collapses inferiorly and the retrohyaloid space is occupied entirely by the syncytic fluid. This process is called acute PVD with collapse and will subsequently be referred as acute PVD. Complications of acute PVD. Following PVD, the sensory retina is no longer protected by the stable vitreous cortex and can be directly affected by dynamic vitreoretinal traction forces. No complications can also occur in acute PVD, and retinal tears is other complication of acute PVD, and avulsion of peripheral retinal blood vessel, which can cause a mild vitreous hemorrhage, which I have told you earlier, which can present as black spots or floaters in front of the eye. Is also a complication of acute PVD. Now, the predisposing factors of pigmentogenous RD include age. The condition of pigmentogenous RD is most common in 40 to 60 years. However, age is not a bar. Now, the age gender-wise most common, it is occurs in male. The male to female ratio is 3:2. Myopia is the most predominant factor which causes pigmentogenous RD. About 40% cases of pigmentogenous RD are myopic. Aphakia, the condition, is another condition which is associated with pigmentogenous RD, is more common in aphakics and fakes. Now, the fifth condition which is associated with rheumatic RD is retinal degeneration, which predisposes to retinal detachment are as follows. Lattice degeneration, snail track degeneration, white with pressure and white without pressure, acquired retinoschisis, and focal pigment clumps. So we should know there are various types of peripheral retinal degeneration near ora serrata, which I have told you earlier. So some type of retinal degeneration causes rheumatogenic RD, and some kind of retinal peripheral degeneration do not cause any rheumatogenic RD. So we should know how to differentiate between this. So the degeneration like lattice degeneration, retinal hole, horseshoe tears, and white with pressure, and these are retinoschisis, or these are peripheral retinal degeneration which can cause RD and hence need treatment. Whereas other retinal degeneration like CRAs and synthetic degeneration do not need any treatment because they do not cause any rheumatogenic RD. Another cause of rheumatogenic RD is trauma. It may also act as predisposing factor for rheumatogenic RD. And then is senile posterior vitreous detachment. It is associated with retinal detachment in many cases. Now, the pathogenesis of rheumatoid and RD, as we have understood from our previous slide, is first senile acute predisposing aphakia, posterior retinal endodermitis, vitreous degeneration detachment causes acute PVD, which can be associated with trauma also, which can cause retinal break. And due to this, the degenerated fluid vitreous seeps through the retinal break and collects as subretinal fluid between sensory retina and pigmentary epithelium and causes RD. Clinical features. Prodromal symptoms. These include dark spots, floaters in front of the eye due to rapid vitreous degeneration, and photopsia, that is sensation of flashes of light due to irritation of the retina by vitreous movement. These are the very important symptoms of rheumatism RD. This include dark spot, floaters in front of the eye due to rapid vitreous degeneration, and photopsia, that is sensation of flashes of light due to irritation by retina by vitreous movements. So if we should consult the patient if you happen any types of photopsia or black spotted in front of her, you should rush to your ophthalmologist because it can be a some initial features or symptoms of rheumatism RD. Symptoms of detached retina. Localized relative loss in the field of vision of detached retina is noticed by the patient in early stage, which progresses through a total loss when peripheral detachment proceeds gradually toward the macular area. Sudden painless loss of vision occurs when the detachment is larger and central. Such patients usually complain of sudden appearance of dark cloud or wave in front of the eye. External exam. Now the signs of rheumatism RD. External examination eye could be normal. Intraocular pressure can be slightly lower or maybe normal. Marcus Gunn pupil with relatively afferent pupillary defect is present in eyes with extensive RD. Plain mirror examination reveals an altered red reflex in pupillary area. Grayish reflex in the quadrant of the detached retina is a characteristic feature in the examination done by the plain mirror examination, which reveals RD. In the ophthalmoscopically, shade should be carried out both by direct and indirect technique. Retinal detachment is best examined by indirect ophthalmoscopy using scleral indentation to enhance visualization of the peripheral retina anterior to equator. Otherwise, it can be visualized. Peripheral RD can be missed if we diagnose it by direct ophthalmoscopy or 78D or 90D, which I have told you in the previous slides or lectures of retina. Now, in rheumatism RD, retina is thrown into fold which oscillate with the movements of the eye. This may be small or may assume the shape of balloons in large bullous RD. In total RD, retina becomes funnel shaped, being attached only at the disc and ora serrata. Retinal vessels appears a dark tortuous spot oscillating with the movement of detached retina. Retinal breaks associated with rheumatogenic RD are located with difficulty. These look reddish in color and vary in shape. These may be round and horseshoe-shaped, slit-like, or in form of large anterior dialysis. Retinal breaks are most frequently found in the periphery. Most common is upper temporal quadrant. Associated retinal degeneration, pigmentation, and hemorrhages may also be discovered. Visual field charting reveals scotomas and also electroretinography in subnormal or absent in RD. Ultrasonography confirms the diagnosis of RD. Complications of RD, this usually occurs in long-standing cases, and which include PVR, that is proliferative retinopathy, vitreoretinopathy, complicated carotid uveitis, and thiasis bulbi. Treatment of rheumatogenic RD includes vitrectomy surgery followed by sealing of retinal bed with subretinal fluid drainage to maintain chorioretinal apposition. We can do scleral buckling, pneumatic retinopathy. Nowadays, it is done with endolaser, 360-degree endolaser, and transplanar vitrectomy with endolaser photoglossy with internal temporary, which is done by silicone oil or various perfluorocarbon gases. Many steps of this process are pars-plana vitrectomy. Pars-plana vitrectomy consists of 3-port. It comes in various types of gauges. It comes under 23 gauge, 25 gauge, 27 gauge. The more the gauge, the finest will be the vitrectomy. So it consists of 3-port vitrectomy with internal drainage of subretinal fluid, flattening of retina, apposition of retina with sealing of retina by endolaser and not by tamponade by retina, internally by silicone oil or perfluorocarbon, and externally by band buckle or scleral buckle. So this is a diagrammatic picture where initially retina was opposed and by the cryocoagulation of the retinal whole area under the direct vision of indirect ophthalmoscopy. But nowadays, endolaser has taken the place of the cryocoagulation. Then this is a diagram depicting scleral buckling and subretinal fluid drainage. Now here we come with the end of the rheumatogenic RD. Now the next type of RD, which is second type of RD, is exudative or solid retinal detachment. It occurs due to retina being pushed away by a neoplasm accumulation of fluid beneath the retina follow inflammatory or vascular lesion. Now, etiology system of exudative RD is systemic diseases. This include toxemia, pregnancy, renal hypertension, blood dyscariasis, and polyarteritis nodosa. Ocular diseases include inflammation such as Harada's disease, synthetic ophthalmia, or osteoscleritis, orbital cellulitis, and vascular diseases under central serous retinopathy and exudative retinopathy of coats. Neoplasm, example, malignant melanoma of choroid and retinoblastoma, that is exophytic type, and sudden hypotony due to perforation of globe in intraocular or intraocular operations. These are the various reasons because of which exudative RD can occur. Clinical features of exudative RD includes absence of photopsia, holes, tears, folds, and undulations. The exudative detachment is smooth and convex. At the summit of a tumor, it is usually rounded and fixed and may show pigmentary disturbances. Occasionally, pattern of retinal vessels may be disturbed due to presence of neovascularization on the tumor summit. Now, the shifting fluid is characteristic by changing position of the detached area with gravity is the hallmark of exudative RD. On trans-illumination test, a simple detachment appears transparent while solid detachment is opaque. Now, exudative RD is a patient with malignant melanoma of the choroid. This is a diagram which depicts exudative RD. Now, the treatment of RD doesn't include vitrectomy as in rheumatogenic RD. Treatment of exudative retinal detachment due to transient exudative hemorrhage may undergo spontaneous regression following absorption of fluid. Thus, the treatment of exudative RD includes treatment of the cause. Whatever the treatment, whatever is the causal factor of the exudative RD, we should treat that. If we will treat that, then that disease, then exudative RD will subside. It doesn't need any vitrectomy surgery. Presence of intraocular tumor usually requires enucleation in exudative, such type of exudative RD. Fractional RD. It occurs due to retina being mechanically. This is the third and last type of RD. It occurs due to retina being mechanically pulled away from its bed by contraction of the fibrous tissue in the vitreous, that is vitreoretinal tractional bands. Now, the etiology of fractional RD includes post-traumatic retraction of scar tissue like penetrating trauma and proliferative diabetic retinopathy, post-hemorrhagic retinitis proliferans, retinopathy of prematurity, plastic cyclitis, sickle cell retinopathy, proliferative retinopathy of Hill's disease. Now, the clinical features of fractional RD is characterized by the presence of vitreous bands with lesions of positive disease. Retinal breaks are usually absent in fractional RD, and retinal breaks are usually absent in fractional RD, whereas it is present in rheumatogenic RD. And configuration of the detached area is concave. In opposed to the exudative RD, which is convex. The highest elevation of the retina occurs at the sites of vitreoretinal traction. Retinal mobility is severely reduced and shifting fluid is absent as opposed as we have seen in exudative RD. So the treatment of fractional RD, it is difficult and requires fast canal vitrectomy to cut the vitreoretinal traction band and internal temporal as described and above in rheumatogenic RDs. Prognosis in such cases is usually not so good. So we need vitrectomy surgery with pars plana vitrectomy with internal temporal and external temporal like rheumatogenic RD. The only thing different in fractional RD surgery is cutting of vitreoretinal traction bands. So in this way, we come to an end of our retina chapter and also retinal detachment chapter. I hope you have all understand different types of um, RDs and different pathologies of retina. Thank you.